Good day everyone. How to solve aesthetic problems. What are the causes of aesthetic defects? Causes of aesthetic defects: 1. Caries. 2. Occlusal disharmony of teeth. 3. Loss of tooth substance. 4. Discoloration. 5. Minor abnormalities. 6. Missing teeth. 4. Classification: Anterior Posterior Non-Invasive, Non-Restorative Aesthetic Treatment, Eye Bleaching II. Microabrasion III. Lumineers IV. Snap-on Smile V. Selective grinding, optical illusion, minimum invasive TTT, Aesthetic Treatment. Modilites, Eye Megabrasion II. Labial Veneers III. Resin bonded bridge. Eye pits and fissure sealants II. Enameloplasty III. Inlay IV. Onlay V overlay 6. Endo-crown VII.Resin bonded bridge. 5. Layering technique using resin: composite, translucent shades, enamel shades, dentin shades, body shades, opaque shades, extra white shades. 6. Composite shades: MW, medium white, translucent. 7. Enamel shade matching. 8. Dentin shade matching. 9. Beveling. 10. Etching. 11. Rinse. 12. Bonding. 13. Silicon index. 14. Palatal shell. 15. Interproximal building using sectional matrix and wedge. 16. Boxing. 17. Dentin thickness. 18. 0.5 mm space left for enamel. 19. Outer layer. 20. Transitional line. 21. Finishing. 22. Tooth morphology, secondary anatomy. 23. Surface polishing. 24. MCO, medium chroma opaque, Tokuyama dental, OBN blue natural, Microabrasion. 25. Color and composites. All smiles have something in common, and that is the colors that make up human teeth shades. From A1 to D4, all shades of teeth express a narrow range of red to yellow color. To match every smile, most composite brands require multiple shades. That's because most composites today depend on the color of red and yellow dyes added to the resin material to emulate tooth shades. This means that dentists must keep a large inventory of different composites to accommodate a variety of patients. 26. Omnichroma blocker. Single syringe. 27. Injection molding technique using bulk fill composite. The BioClear method is a direct overmolding technique where heated, preferable, bulk fill composite resin or dual cure composite is injected into anatomic matrices, resulting in a tooth shrink wrapped in a monolithic form. The BioClear method can create strong, void-free, stain-resistant restorations with incredible shine retention, infinity margins, and smooth, convex subgingival contours when done well. Hand-layered composite is prone to incorporation of seams and voids that contribute to structural weakness, overhangs, pitting, and staining of the restoration. 28. Diastema closure using injection molding technique. 29. Chairside smile design. This offers the advantage of diagnostic planning done with clinical photography instead of time-consuming study models and diagnostic wax UPS. 30. The grid serves as a multifunctional tool, enabling the clinician to visualize the mesial to distal projection and symmetry of the smile based upon the central incisor width. As a visual tool, the grid can aid the clinician in adjusting the smile proportionality to achieve a conservative and aesthetic outcome. 31. Class 3 restoration using the BioClear matrix with injection molding. A contact easy saw is taken to clear the contact of any tartar buildup. A contact easy one-sided sanding strip is used to lighten the contact to aid in placement of the matrix. 32. Labial veneers. Laminate veneering is a conservative method of restoring the appearance of discolored, pitted, or fractured anterior teeth. It consists of bonding thin ceramic laminates or composite restoration onto the labial surfaces of affected teeth. 33. Types of labial veneers: partial labial veneer with direct composite restoration. Full labial veneer, and it has two types: I. Direct composite restoration. 2. Indirect porcelain restoration. 34. Indication: gross aesthetic derangement as gross discoloration. Mottled enamel in fluorosis, imperfection in contour of surface texture of upper anterior teeth. 35. Contraindication: bruxism, occlusal interference, excessive incisal wear, class 3 malocclusion because of the great possibility for dislodgement. 36. General role of preparation: the average preparation of the depth half of the enamel 0.5 to 1 mm mid-facially and 0.2 to 0.5 mm along gingival margin or as the case require. Definite finish line. Incisal edge is not included. If included for anterior guidance, tooth reduction of at least 1 mm. Margin at crest of gingival tissue. Preparation extend only in proximal line angle unless there is proximal caries. The facial surface should be reduced in 3 planes. 37. Types of preparation: I type: I window preparation, feather, in which the veneer is taken up to the height of the incisal edge but the edge is not reduced. 2. Type 2 butt joint preparation, 2 mm or 1 mm incisal reduction without palatal chamfer. 3. Type 3 wraparound preparation, 1 mm incisal reduction with 1 mm height palatal chamfer. 38. Window preparation preferred in direct composite veneers. Preserve lingual and incisal surfaces. Significant occlusal function. Preservation of functional surfaces reduces wear of opposing tooth. 39. Butt joint preparation. Lengthening of tooth incisal defect facilitates seating of veneer. 40. Wraparound preparation. It includes labial and palatal reduction. It restricts angle fractures. When the free edge is not overlaid, the occlusal third of the laminates are very thin, less than 0.3 mm, and liable to fracture. It enhances aesthetic properties of laminates. 41. Burrs used for laminate veneer preparation. 42. Labial preparation of laminate veneer. The preparation of the labial contour of anterior teeth needs to be addressed in 3 planes: incisal, middle third, and cervical. The labial contour has a convex surface. The enamel thickness at the gingival third is 0.3 to 0.5 mm, up to 0.5 to 1 mm at the middle third and 1.0 to 2.1 mm at the incisal third. 43. Labial preparation of laminate veneer. All efforts should be made to keep preparation within the enamel for long-term adhesion and also to avoid any unnecessary tooth structure removal. Veneers may be used to mask discoloration. A porcelain veneer needs a minimum thickness of 0.2 to 0.3 mm for each shade improvement if discolored, or alternatively a more opaque shade composite/porcelain can be chosen. 44. Use of depth cutting burr to initiate depth of reduction required. 45. Using round tapered stone or flat tapered stone to reduce the graded depth cut. 46. Preservation of the enamel using mock-up during laminate veneer preparation. 47. Bleaching. Bleaching has become a routine, popular, conservative option with a high rate of success for treating moderately stained or discolored teeth. Bleaching techniques are preferred because tooth color can be regained without removing sound, healthy tooth structure. The desire for whiter teeth is very strong, and tooth bleaching safely lightens the color of the teeth, lasting for up to 3 years. 48. Material and mechanism of action. It is mostly an oxidation reaction using hydrogen peroxide or carbamide peroxide in the concentrations of 30 to 38%. It could be in home or at office application. It could be vital or non-vital tooth bleaching. It may depends on light, laser to accelerate bleaching process, or it does not depends on light at all. 4986. 50. Bleaching, extracoronal or vital bleaching. 1. Dentist applied in office techniques: light activated bleaching, laser activated bleaching, ozone activated bleaching, ultrasonic activated bleaching. 2. Dentist prescribed / administrated at home techniques. 3. Dentist provided bleaching. 4. Over-the-counter products applied by the patients at home. 51. Bleaching, intracoronal or non-vital bleaching, direct or walking bleaching. 52. Intracoronal bleaching. 53. Icon resin infiltration concept. White spots after orthodontics, early incipient caries. 54. The challenge: treat caries while preserving healthy tooth structure. Until now, dental professionals have had only two choices in the treatment of caries: use fluoride and other treatments to remineralize enamel in the very early stages, or wait and see until it's time to drill and fill. 55. Icon represents an entirely new, revolutionary approach to treatment of incipient caries, a caries infiltrant. This breakthrough micro-invasive technology fills and reinforces demineralized enamel without drilling or anesthesia. 56. Icon resin infiltration concept. 57. Microabrasion. Microabrasion offers a conservative approach with minimal loss of enamel surface. Enamel microabrasion could remove stains from within the outermost layer of tooth enamel, thereby improving the appearance of the tooth. 58. Material and technique. The microabrasive materials used for this purpose are: iChemical, enamel microabrasion slurries containing approximate 6.6% hydrochloric acid, e.g. Opal-Uster, delivered via a syringe for fast, easy application and provide a natural glazed enamel surface. This microabrasive material can correct demineralization defects up to 0.2 mm in depth. 2. Mechanical, polishing cup and polishing brush are used to remove superficial stains after application of Opal-Uster. 59. Opal-Uster. 60. Megabrasion, macroabrasion. Megabrasion technique is another adjunct treatment modality that represents a useful and predictable approach for the elimination of white opaque stains of enamel. 61. Material and technique. Clinicians are often intimidated by the idea of mechanically removing these stains. Erase such white enamel spots is by total mechanical eradication of the lesion and subsequent restoration with a neutral and translucent composite. 62. Lumineers. Lumineers are a brand of porcelain veneer that can be fitted to the existing teeth without the need to drill or grind them down. However, even with lumineers, it is sometimes necessary to smooth down a minimal amount of tooth structure. 63. Lumineers. The main advantage of the lumineers is that your natural teeth are being preserved and there is usually no sensitivity, compared to traditional veneer preparation techniques. 64. However, there are some potential disadvantages. With no preparation, not only will teeth feel thicker, but there can be a thicker edge at the gum margin, which can cause gingival inflammation. Additionally, lumineers are much thinner than other types of veneers, and as such, the lab technician cannot build in as much depth of color. This can make it more difficult to mask darkly discolored teeth, and a less aesthetic outcome is the result. 65. Laminates vs lumineers. 66. Laminates vs lumineers. 67. Snap-on Smile. Snap-on Smile is a non-invasive cosmetic, removable full or partial arch that literally snaps right over the patient's existing dentition without impinging on the gingival tissue or covering the palate. Entirely tooth-borne, no adhesives are required and patients are free to eat, drink and function normally without obstruction. 68. Snap-on Smile. It is made of a crystallized acetyl resin, which makes it more durable and stain-resistant, as opposed to acrylic, and allows it to be as thin as 0.5 mm without compromising its strength. It is this minute elasticity that allows the appliance to gain its retention by flexing over the heights and contours of the existing teeth. 69. Snap-on Smile. 70. Ugly truth of snap-on smile. 71. Selective grinding. Reshaping of natural teeth by grinding them with diamond tools and polishing with fine sandpaper discs for cases that require removal of only part of enamel thickness. Indication: 1. Crowed, malposed or super-erupted teeth. 2. Eliminate minor mismatch in tooth form. 3. Establish symmetry. 4. Provide better aesthetics without any considerable cutting of tooth substance or material application. 72. Principles of illusion. 73. Principles of illusion. 74. Principles of illusion. 75. Contraindication. 1.